The rules. All participants are requested to kindly note the rules. Please end it. Please sit down now. So, Bhabatosh sir. Sir. हाँ सर. सर आप ही खेलिए सर. आगे सर. बल सर आगे. बल सर आगे. सर कनाई को. सर अरे all of them are. Sir, we can have 6 judges also. Then let's have only this one as they prescribed. And if you want Anula can also be judge. Anula, come on. Yes, you are a professor. Come on. Sir, आप ही आ जाइए. We are starting the quiz activity. So for everyone, especially the participants and the judges, please kindly understand the rules. We are having 2 rounds where there will be 3 questions to each, 3 questions which will be asked in each section. So every team has to answer 1 question in that section, and all the team members have to will have time after the clinical scenario to decide which question they want to answer, but it is mandatory for every student to answer 2 questions. Please make sure that you're supporting your team members, but everybody gets to answer 2 questions.
Is it clear?
So each question will have 2 parts, part A and part B. Any student who starts answering has to answer the complete question. You cannot just take part A and say that my other colleague will give answer to part B. You have to give answer to both parts yourself. For each part, you will be marked from 1 to 5 by the judge panel. So based on your marks, we'll be collecting, and then this is how the awards go. So the team which wins the maximum, that is if you use good teamwork and you get the maximum marks, then the first team's prize gets divided into 25, 15 and 10,000. The second team's prize money gets divided as 15, 10 and 5,000, and third team 10, 6 and 4. So please make sure that you are helping each other in winning. So judges give so scientific feast. So
We will all be allowed to get 1 pack extra.
So we are starting with the first section, that is lung cancer. We are going to start with the team NITRD, followed by team Kerala, followed by team Karnataka, and then thoracic surgery team from Medanta plus Gangaram. So please follow this order in all your further things. So this is the
Instructions for us.
sir. After each part, you have to give them marks based on what you think is their approach. The one of this. And the marks do not necessarily have to be for the correct answer. The marks have to be for their clinical approach to answering a question. So I would request the yes, ma'am. I would request the quiz participants to kindly introduce themselves once.
Hello, I'm Dr. Prerna, senior resident in NITRD.
I am Dr. Vinay, senior resident in NITRD.
I'm Dr. Sunita, resident in NITRD.
I am Dr. Dhaval from Government Medical College, Kottayam.
I am Dr. Paras from Government Medical College, Kottayam, second year resident.
I am Dr. Dinesh Kumar, senior resident from Government Medical College, Kottayam, Kerala.
I am Dr. Karan from Narayan Rudayalaya, third year CTVS.
Dr. Deepanjana from Narayana Rudayalaya, first year DRNB thoracic surgery resident.
I am Dr. Shrishti, fourth year resident from National Heart Institute, DNB CTVS.
Hi, I am Dr. Rachita. I am first year resident in DNB thoracic surgery at Medanta.
I am Dr. Harita, first year resident in thoracic surgery, Gangaram.
I am Dr. Rahul, first year resident from Medanta Hospital, thoracic surgery.
So the first question is, a 67-year-old gentleman with known single vessel coronary artery disease developed COVID-19 and was advised HRCT thorax. He is a known smoker with 30-pack years history of smoking. He instead underwent a CCT thorax, which was suggestive of this. So you can see a nodule in the right lower lobe. It was a 1.8 centimeter nodule with no significant mediastinal nodes and no COVID-related lung changes. This question is for team NITRD. Please see the options carefully. The case was discussed in thoracic oncology MDT and his Brock risk score was 18%. So now I'll be putting up the first question. So team NITRD, who's answering? Dr. Sunita. So Dr. Sunita, which of the following is acceptable? Review previous imaging and advise follow-up if the size of nodule remains the same at 1 year. Consider a repeat CECT at 3 months. Do PET CT and biopsy if Herder score is more than 70%. Do PET CT and advise VAT surgery if Herder score is more than 70%.
Ma'am, I will go with the option 2. Consider repeat CECT at 3 months.
We would request the judge panel to mark the candidate based on their answer. So the correct answer based on literature evidence is if you've done a Brock's risk scoring based on BTS guidelines and there's a high risk, you advise a PET CT, and if it is a Herder score of 10 to 70%, then you're supposed to do a biopsy, and if it is more than 70%, then you have to say that there's a very high risk of malignancy and patient should be taken for surgery. So that's the right answer. So Sunita, the next question is now this patient underwent a FDG PET, where there were no avid hilar or mediastinal lymph nodes. So the next question to you is regarding workup, which is false. Please make sure that you read the question carefully, which is false. Invasive mediastinal staging should be done. Smoking cessation, chest physiotherapy and PFT should be done. 2D echo is essential after ECG in this patient. MRI brain is not indicated.
Ma'am, according to me, option 1 is false. Rest of the 3 options are correct.
Maybe ask the judges to please mark the student. So, Sunita, you've come up with the correct answer because it's a peripheral lesion which is less than 3 centimeter. Invasive mediastinal staging is not mandatory for this patient. 2D echo is essential in this patient, not routinely, because one, he's 67, and second, he had a CAD previously. Smoking cessation, chest physiotherapy and PFT, of course, you won't do lung surgery without that, and MRI brain, again, single small lesion, not stage 1 disease, not indicated. Going on to the next question for team 2. Please listen to the clinical scenario. There is a 63 years gentleman who's a non-smoker with no known comorbidities. He completed treatment for clinical stage 2 colon cancer 8 years ago. He has been on follow-up with no abdominal symptoms and normal follow-up scans. He underwent a CECT chest with abdomen now and was referred to you with the following scan. His CEA at this time was 4.2. So this is the scan. As you can see, there is nodules in both the left and the right lungs. I hope that's visible. There is one on the left side, which this is the lung window and this is the mediastinal window, and one on the right side, the mediastinal window and the lung window. So you advised a PET CT and there was no uptake in the abdomen. So abdomen wise, he is disease free even today. So I would like to ask team 2 who will be taking this question. So Dhaval, the question for you is, all are true except. So please be very sure that you are understanding all are true except. In view of bilateral nodules, the differential diagnosis of colon carcinoma metastasis is more likely. The presence of air bronchogram and spiculated margins makes the biopsy likely to be bilateral synchronous primary lung cancer. The differential uptake on both sides and absence of mediastinal lymph nodes makes the diagnosis of left-sided carcinoma lung with right-sided metastasis more likely, and fourth option is none of the above.
Option 3.
We would request the judges to kindly mark.
3. That is false. 3, sir.
Yes. Please mark. So, Dhaval, this was the most appropriate answer based on literature. Why? Because in view of bilateral nodules, we cannot rule out carcinoma colon. And what is more likely in this patient is that because there are no lymph nodes, it could be double primary, that is synchronous primary in both lungs, which may or may not be the possibility. So we've looked at this patient, and this is the IHC staining of the left lesion. So we have shown you a picture of the TTF staining as well as the CDX2 staining. These are the two markers that help us in differentiating a colon cancer from lung cancer. So based on this IHC, what will you do next? Your options are EBUS guided mediastinal lymph node evaluation, on-table mediastinoscopy and left lower lobectomy with systematic lymph node dissection if no N2 nodes on frozen section, bilateral metastatectomy, bilateral segmentectomy with SMLND.
Option 3, bilateral metastatectomy.
I would request the judges to kindly mark. Yeah, we've shown him the pathology. TTF staining as well as CDX2 staining. Yes. He chose bilateral metastatectomy as his answer. So the answer we found based on literature was EBUS guided mediastinal lymph node evaluation. Why we came to this answer was that because we don't know the status of the mediastinal lymph nodes and PET-CT is not sufficient to give us that answer. So we cannot label them as bilateral synchronous primary until we have an evidence of negative mediastinum. Why on bilateral metastatectomy is not the answer? Because this patient has no uptake on CDX2 and very high uptake on TTF1 staining. TTF is the marker for adenocarcinoma lung. So if you have uptake on TTF1, then it is more likely to be lung cancer. Yes, that is very true, sir.
And one more thing, tumor size is less than 3 centimeter, ma'am.
Yeah, but this is bilateral synchronous primary is a differential here. So in bilateral synchronous primary, you have to at least rule it out.
Okay.
No, but if you say EBUS, you're groping in the dark. You don't have any mediastinal node. You're talking EBUS for the peripheral lesion. I mean, people do it. Right?
No, sir.
So for the mediastinal staging is still advised.
Mediastinal staging is that's the answer based on literature evidence that we also found. So next question is for team 3.
Only for the right level 2, 4
A 58 years gentleman, known smoker with 20 pack years of smoking, presented with right-sided chest pain for 3 months and recent onset cough. He walks 6 kilometers every day and has run multiple half marathons in his life. He underwent a CCT thorax, which was suggestive of this. So you can see there's a lesion in the right upper lobe, which is, these are the 2 lung windows and this is the mediastinal windows of the lesion. Which?
I'll be taking Karan.
Karan. So Karan, this is the question for you, which is fall regarding staging investigations. PET-CT should be done for staging for distant metastasis and for decision making for EBUS guided mediastinal staging. MRI brain must be done as PET does not have adequate sensitivity to rule out brain metastasis. MRI thoracic inlet and neck should be performed before surgical planning as this patient has a Pankos tumor, none of the above. You have to tell me what is false.
Just phone a friend option is open.
we have a timer for discussion?
2 is false, ma'am. Sorry? 2. MRI brain must be done as PET does not have adequate sensitivity. Second
So
one.
can we request the judges to kindly mark the answer? Okay, so the correct answer is that yes, PET CT has to be done for staging, but PET CT is only for distant metastasis. It cannot help you guide your decision of whether invasive mediastinal staging should be done or not. It is very important to know PET, especially in our country with tuberculosis, has uptake and there is no congruence. So invasive mediastinal stages has to be done irrespective of the PET. MRI brain, any tumor which is more than stage 1, MRI brain is an essential investigation. PET CT does not have adequate sensitivity to detect brain metastasis. And if you are operating on a pancreas tumor, then yes, you will need to look at the vessels before you proceed for your surgical planning. So the next question for you is, we did a metastatic workup in which PET CT showed a right upper lobe lesion 4.9 centimeter with extension into the first intercostal space. In MRI brain, there were no mets, EBUS negative. So clinical stage was T3 N0 M0. So what will be your next best approach? Would you want to give neoadjuvant chemoradiotherapy followed by reassessment with CT and MRI thoracic inlet and proceed with right upper lobectomy with first and second rib excision with SMLND? Or would you want to do a right upper lobectomy with first and second rib excision with SMLND via the modified Dartwell approach with adjuvant chemotherapy? The third option is neoadjuvant chemotherapy followed by reassessment with CT and MRI thoracic inlet and proceed with right upper lobectomy with first and second rib excision with SMLND with adjuvant radiotherapy. And your fourth option is definitive chemoradiotherapy.
Right upper lobectomy with first and second rib excision with SMLND with via modified Dartwell approach.
I would request
and adjuvant chemotherapy.
I would request the judges to kindly mark the answer. Okay, so the correct answer based on literature that we found was neoadjuvant chemoradiotherapy. Whenever the tumor is invading the chest wall or being causing more extensive dissection or this thing, neoadjuvant chemo, any pancreas tumor, neoadjuvant chemoradiotherapy followed by surgery is the standard of care. So that's based on best literature evidence. We move on to the next question for team 4. A 48 years old gentleman who's a smoker with good performance status and no known comorbidities, he presented with chest pain and cough. On systemic examination, there was no findings and he was advised a CT thorax. So this is a CT thorax. As you can see, this is the lesion on the mediastinal and the lung windows. On staging investigations, a PET showed a 4.2 centimeter left lower lobe mass with ipsilateral hilar lymph nodes, no brain metastasis. EBUS was station 7 positive on cytology. So final diagnosis is carcinoma lung CT2N2M0. So who takes the question?
I'll take the question.
Yeah. So you have to tell me what is false. Neoadjuvant chemoimmunotherapy followed by left lower lobectomy with SMLND should be advised. Upfront surgery followed by chemotherapy and neoadjuvant chemotherapy followed by surgery will both have similar 5-year overall survival in this patient. Neoadjuvant immunotherapy followed by left lower lobectomy with SMLND should be advised, or none of these are false.
2. Option 2 is false, ma'am.
Option 2 is false. I would request the judge panel to kindly mark.
Option what?
Option 2.
Option 2
Saying
is
is false.
Yeah.
I'm not sure about this question, these answers actually.
Okay.
So, but for the fairness of students, please.
No, but you can look at the other judges. It's fair enough to allow us our opinion as well.
Mm-hmm.
So,
Yeah.
So you can look at the other judges.
So you can
and-
divide by 4 if 4 people have marked.
Yeah, okay.
Okay, thank you, sir. So the correct answer was that the false option is neoadjuvant immunotherapy followed by left lower lobectomy, because the standard of care today is neoadjuvant chemoimmunotherapy. And the second option is correct because there is no literature evidence today that proves upfront surgery versus neoadjuvant chemotherapy has better overall survival or not.
But how often and how many centers can do immunotherapy?
Sir, we are not looking at the logistics. For students, we are looking at evidence-based medicine today for the quiz.
Your point is taken, sir.
So the next part for you is that this patient could not afford chemoimmunotherapy, just as Sri Krishna sir said, and was opted for NACT followed by surgery. So which do you think is true? What would you do now? Which is true? Response assessment after NACT with CCT thorax and invasive mediastinal staging is not sufficient. Since EBUS was used for initial mediastinal staging, now upfront mediastinoscopy should be advised. If there is complete resolution on response evaluation, CT, patient must be kept on follow-up. Which is true or none of the above?
None of the above.
So I would request the judge panel to kindly mark the. Yeah, thank you. The answer is correct. It is none of the above. Why? Because response assessment, there is no study which says that PET CT is better than CT for response assessment after neoadjuvant chemotherapy. The second choice is true because
That's what the second choice
sorry,
is.
sir. The answer there is 2. Since I'm sorry, it's just wrongly marked. I'm really sorry. The answer is 2 because even if EBUS has been done for initial staging, you can repeat an EBUS, and if that is negative and you want to do, you can do a mediastinoscopy. I'm really sorry for this.
So 4 is wrong.
So 4 is wrong. The answer has to be since EBUS was used for initial mediastinal staging, now upfront mediastinoscopy should be advised. So now we move on to the next section of the quiz, that is on lung infections, and I'll ask my colleague Saransh to take the questions.
Good evening. That was an exciting first session. A lot of controversies. Moving on to team number.
Give them some encouragement, no?
Yes,
Quick
yes,
Master
yes.
has to say something.
Can we have a round of applause for the first round, especially for the judges and the team members as well?
You must talk like Amitabh Bachchan.
Yes, sir.
कौन बनेगा करोड़पति?
अगला सवाल.
अगला सवाल बोलो.
10,000 रुपए की. Moving on to the second session, lung infections. Team number 1 from NITRD. There you go. 28 years young lady with no known comorbidities presented and was diagnosed as pulmonary tuberculosis in November 2016. On LPA, there was isoniazid as well as rifampicin resistance detected, and she was started on capreomycin, imipenem, moxicillin, pyrazinamide, clofazimine, amoxicillin, and ethanoamide in February 2017. She had no improvement of symptoms and developed an episode of hemoptysis, which was controlled within 3 days with medications. However, her cough worsened and MGIT report was XDR. At this time, her sciogram as well as CT were as follows. You can see a right upper lobe lesion clearly in the CT and the X-ray. In view, you want to see the X-ray more? You good? In view of the poor response to above therapy, she was started on bedaquiline-based regimen, and the patient achieved sputum conversion at 3 weeks of bedaquiline therapy. Now she has persistent cough, but her hemoptysis has not recurred. So the question is, who's answering the question? So the question is, what should be her next management? Option 1, continue bedaquiline-based therapy for 5 weeks more and then consider her for surgery. Option 2, consider her for surgery now since she has achieved sputum conversion. Option 3, no significant hemoptysis and hence consider for continuation of bedaquiline-based therapy. And option 4, continue bedaquiline-based therapy and do prophylactic bronchial artery embolization.
Sir, I think option 3, since she does not have any significant symptoms as of now, so we'll continue the therapy and after that we'll reevaluate after 4 to 5 weeks.
Judges, the option chosen is 3. Scored well on that one. Moving to the answer based on evidence.
That's the right answer. Consider it first.
The first option is wrong. Why? Because the patient has had hemoptysis. If the patient was symptomatic only, then we could consider this as a reasonable option because bedaquiline-based therapy has to be continued for 3 months. If the patient is improving, if the patient gets hemoptysis, you cannot just keep waiting. And since she has achieved sputum conversion, this is the right time to operate.
See, she has a large enough cavity, so she needs to be operated. Otherwise, she may become sputum positive again. Number one. That's what I said in my talk. So this case is an ideal one. That's why this is okay.
But didn't your talk also say give 5 weeks?
She has already received that therapy. And
She's received that therapy, sir.
No, she has not developed hemoptysis thereafter.
No, but after that it has stopped.
Yeah, stop.
So getting hemoptysis once is good, is the reason why she should be considered for surgery at sputum conversion. If there was no symptoms, then surgery can be, then the patient can be on medical management alone or to continue with this.
You're talking 5 weeks and 3 weeks. You're talking 2 weeks.
No, sir. She already received bedaquiline-based
Yeah.
therapy
She'd already received therapy.
for a long time.
And you're talking about another
Or increasing it for just 5 more weeks.
5 more weeks.
Yes.
So by the time they decide, it'll be 5 weeks. Chalo,
Yes.
chalo, next question.
Part 2.
Anyway, another answers are there's no decision.
Yeah,
on that.
exactly.
Okay.
Exactly.
Sure.
The multidisciplinary team decided to offer her surgery and she was taken for surgery at 4 weeks of completion of bedaquiline-based therapy. And her sputum status was negative prior to surgery. Her PFT was an FEE1 of 100 and her PPO FEE1 was 47.37 for pneumonectomy and 84 for right upper lobectomy. Intraoperatively, she had multiple nodules in the right middle as well as the lower lobes. What surgery should be offered at this moment? She should be offered a pneumonectomy, she should be offered a right upper lobectomy, or surgery should just be abandoned, or she should undergo a right upper lobectomy with wedge resection of the nodules in the right middle lobe and the lower lobes.
Sir, I think we would offer her a right upper lobectomy. The nodules might resolve with medical management also.
Sorry?
We'll offer a right option 2, sir, right upper lobectomy. The nodules might resolve with medical management.
Okay. Remarks?
3, 4. I won't give her 5. She can take a.
Sir?
Me? I was the first.
Okay. Thank you, sir.
Thank you, sir.
The answer actually is option 4. She should undergo right upper lobectomy with wedge resection of the nodules in the right middle and the lower lobes.
Correct.
When we are taking for surgery, we have to do the complete job. If we are not offered her surgery, then we would think of more conservative.
Taking a biopsy, yeah.
Moving to the next question.
And pneumonectomy should be avoided in a benign disease.
Absolutely.
Yes, pneumonectomy should be avoided.
Especially for MDR-TB, there has been studies which have shown that there is worsening of outcomes with pneumonectomy for MDR-TB. So based on ATS guidelines, pneumonectomy is contraindicated in MDR-TB.
Not contraindicated, the whole lung is involved.
Exactly.
Not to be offered.
Lung sparing surgery is always the norm. Moving to the next team. Who's going to take it?
I'm going to.
Question number 2. A 28-year-old young lady presented with recurrent hemoptysis for the past 3 years. She had developed pulmonary tuberculosis in childhood and was completely cured then. On imaging, she was noted to have right upper lobe complex pulmonary aspergilloma with calcified Gons complex, with slight chest contraction with pleural thickening. Her right, middle and lower lobes as well as left lungs were grossly healthy. Her PFT was FEE1 of 100% and DLCO 104%. Her performance status was ECOG1. You know who's taking the question?
Yeah. I'm Dr. Paras.
So part 1. What is the best course and why? She should be offered minimally invasive right upper lobectomy. She should be offered open thoracotomy with a right upper lobectomy. She should be advised to continue on follow-up until she develops life-threatening hemoptysis, or she should be referred for an urgent bronchial artery embolization.
Option 2, she should be offered open thoracotomy with right upper lobectomy, as she had a history of hemoptysis, plus now she right middle and lower lobes are normal, and she is open thoracotomy will be better in presence of a calcified Gons complex.
Why not 1? answer. No, mine.
There is a adhesion to, there's an adhesion to the chest pleura.
You don't know?
It is there. They told first.
And there is a calcified nodule.
Calcified Gons complex.
And also you said that it's a complex aspergilloma.
Yes.
And your expertise will not be good. Yes, you can still do it. Yeah.
That is the right answer. Very well answered. Paras,
Wow.
round of applause. That's the first concurrence between the judges, the quiz master and the candidate. Moving to the second part now. Which is false? In the robotic surgical SI system, it is not possible to divide the adhesions below the trocars. If we place the patient cart at an angle of 175 to 185 degrees to the patient's head instead of 15 degrees, it becomes easier to divide the adhesions for the diaphragm. Number 3, if there are dense adhesions based on imaging, preoperative embolization may be considered to facilitate minimally invasive approaches. Or number 4, chest wall adhesions account for the most common reason for conversion in patients undergoing minimally invasive lobectomy for complex pulmonary aspergilloma. Which is false.
Which is false, yeah.
Option 3 is false because the preoperative embolization will not help in a case of dense adhesions in minimal invasive approaches.
This one. Bowser is not answered yet. He's taking this, okay. Fair enough.
So number 3 is false. That's what you say.
Yes, sir. Because that's not going to help in the minimal invasive approach.
And the answer is chest wall adhesions account for the this is false. Chest wall adhesions do not account for the most common reason for conversion in patients undergoing minimally invasive lobectomy for complex pulmonary aspergilloma. This is false.
There's a study from AIMS, if you read about this preoperative embolization and how it helps them to minimize the time invested in adhesive lysis.
Yes.
There's a published study.
Nowadays, chest wall adhesions can be lysed easily. If the difficulty occurs near the mediastinum and vessels, then you convert more often, or a dangerous bleeding experience. Those centers which are committed to doing minimally invasive thoracic surgery.
I mean, I agree that you've chosen some case, but I think sort of, there is a total lack of consensus on many of these answers.
Yes.
And I don't think that we should choose these kind of questions for a quiz. It should be absolute, I mean, these are very opinion-based issues.
Grey areas. Anyway, your answer is also well
This
taken.
one is a little more, but others were.
Your answer is also well taken.
I mean, there is nothing to suggest in literature that if you do preoperative embolization, that it facilitates minimally invasive procedures. No, I know. AIMS publication is one of 108 publications.
No, but see,
it's not
when you say which is false, among the 4, the third one is actually this thing. Correct. Minimal invasive technique, the embolization does not help.
Okay, so based on the judge
And your quiz master's decision is fine.
No, that's fine. That's fine. No, what we are trying.
are getting marked on the judge's decision as well, and we are happy to learn. So yes, we can consider the self.
And the second issue is I want to suggest is that the first 2 options are not good options for the simple reason there would be centers in which there would be no SI, there would be no robot in the first place, or an SI, right? So I mean, frankly, if you ask me, I don't even know whether that second option is correct or not.
And when we decided the open approach in the first question, the robot does not even figure it.
So I think next time, I mean, since we are the first time, all of us are learning, and I think
So we're also learning, but
sure.
But to just say that we are also analyzing what our candidates are saying. So their answers could actually be what they practice, and we could And you guys could be happy with their answers. So the answers don't actually carry any weightage here. Their performance is what we are actually judging.
We have deliberated these questions and decided the best possible answer in our consensus. So, as of now.
No.
Moving on.
So Saransh,
yes, sir.
Let's be clear to all of you young people. What you think, stick to it. This is not going to guide your final marks. The final marks come from here.
The marks are already
right?
Back up your answer.
Yeah. So your analytical skills are more important than.
So don't go by this alone.
You should be able to explain what you're saying.
Justify.
And
reasoning.
Sometimes in medicine there is no perfect answer.
Sure.
Yes.
That is.
The third question for the third team. A 40-year-old gentleman presented to the emergency after a massive bout of hemoptysis at home. According to his wife, there was 1/4 mug full of blood in the sink. The patient was successfully resuscitated and did not require intubation at that time, and post-resuscitation, he had a pulse of 100 per minute and a blood pressure of 110/70. After initial stabilization, a detailed history was sought. There was a significant positive history of 30 years of smoking and a past history of tuberculosis 20 years back, and he was declared cured after successful treatment at that time. There are no known comorbidities, but there is a history of lung cancer in his maternal grandfather, and there is no history suggestive of coagulopathy. So who's going to take this question?
Dr. Shrishti.
Shrishti. Which is false? Number 1, do an immediate PFT for emergency thoracotomy if necessary. Number 2, order a CECT thorax with angiography and consider for bronchial artery embolization. Number 3, arrange adequate blood products. Number 4, keep a low threshold for intubation to secure the airway and do an FOB at the time of hemoptysis to localize the site of bleeding.
Option 4, keep a low threshold for intubation to secure the airway.
Which is false.
Which is false. You
Yeah.
what is false.
I hope you got the hint. Which is false.
Which is false.
Option 1, sir.
Good.
Sir, in case of massive hemoptysis, we do not do PFT.
To me, it's good. And I shall say it's good.
Rather easy
Fine.
one, huh?
Yeah, you can't make a mistake. Yeah.
Classes are given.
Yeah. So I didn't want her to be embarrassed,
So, correct.
I think
That is the-
declaration, ये conflict of interest declare करना.
मुझे कोई इंटरेस्ट नहीं है इंटरेस्ट तो कुछ और कहीं और है
Answer is internal like that.
So, moving on, this was the CT scan of the patient. You can see a right upper lobe something, if you should know what that is. And that is the X-ray and that is the CT scan of the lung. So there is a right upper lobe cavity with no marks for this. I'm just playing with you. No, this is not the question.
The question is coming.
Yeah, the question is coming.
Somebody should answer his answer.
This is just to warm you up.
Right upper lobe cavity.
He's asking with what?
With what?
With what? It's a right upper lobe cavity with a fungal colonization or a fungal ball. Yeah. And this is again a CT scan showing a right upper lobe cavity. Moving on. You can have this image. This image is clear?
Yes, sir.
Yeah? The patient had a second bout of hemoptysis of 3 to 400 ml after 4 hours. However, in view of ongoing blood transfusion, there was no shock. His approximate total blood loss was about 700 to 800 ml over 6 hours. What should be done next? An emergency right upper lobectomy, a bronchial artery embolization as a temporizing measure followed by right upper lobectomy in an elective setting, a bronchial artery embolization followed by right upper lobectomy within 24 hours of bronchial artery embolization, or an endoscopic management of hemoptysis and antifungal therapy with surgery only if there are more than 3 episodes of hemoptysis that occur in 1 year.
Sir, bronchial artery embolization. Option 2, sir. Bronchial
Option
artery
2.
embolization as a temporary measure followed by right upper lobectomy elective setting.
The judges? And that is the correct answer as per evidence. A bronchial artery embolization as, thank you, please. As a temporizing measure followed by
I have an
rhipitomyelin.
objection. When you do
Yes.
bronchial artery embolization, you cannot wait for too long. You can't wait. You should do it within a week.
That is.
So that is what, we just said that not immediately, you do and then don't do.
You said elective
24
setting
hours.
there.
And then, so within 24 hours or in, once the patient is stabilized.
Okay, 24 hours too early, that's what.
24 hours is too early, elective setting is too late.
Elective
setting
setting is too late.
7 days is the right answer.
7 days is the right.
As early as possible.
Okay.
ASAP.
This is semantics.
We just meant that reason, 7 days. But yeah.
Within 14 days, 1 month, it's okay.
And what happens, sorry, bronchial artery embolization fails?
Then of course.
So that's for the next year quiz.
That happens. No, because
That's for the next year quiz, sir.
emergency right up.
Come on, 2 more rounds to go,
The
right?
next team. A 45-year-old gentleman who is a known case of diabetes, controlled for the past 9 months, developed high-grade fever with drop in saturation while in lockdown 1.0. He did not seek consultation for 3 days for the fear of forced hospitalization and subsequently recovered spontaneously. He did not get vaccinated even during the second lockdown since his personal belief was that he had recovered from COVID. During the second wave, he developed a severe breathlessness with fever and was hospitalized for COVID. His CECT chest was suggestive of, who's taking the answer? Okay. Harita, right? Yes. Yeah. This was his CECT. He was managed with ventilatory support and gradually improved over 3 weeks and was discharged at 4 weeks with slightly raised sugars but no oxygen requirements. 3 weeks later, he had a bout of hemoptysis and underwent another CECT chest which was suggestive of this. He is unable to perform PFT and his sugars fasting are 400 and postprandial are 450. Harita, what is the next course of management?
So, option 3, surgery after 48 to 72 hours of antifungal cover.
Right. Wait for the judges.
You're not supposed to turn back, Richard.
So they cannot see the marks.
That's all right.
Oh yeah, you're fair.
Some people are, that's home institute.
That is the right answer. Thank you. Great job, Harita. But the question is not over. He was taken for surgery and a right upper lobectomy was done. There was intraoperative blood loss of 4 liters and the residual lower lobe was not expanding well on table. He had a turbulent post-operative course and developed diabetic ketoacidosis, which was managed with fluid therapy. On day 3, he was weaned off the ventilator and a chest cardiogram was suggestive of a right apical space. A negative pressure chest drainage system was reapplied, but the air leak remained to be about 1,000 at 10 centimeters of water, and there was no BPF on bronchoscopy. What would you do next?
So you can
He got weaned off after 3 days.
Yes.
And that is when they eliminated 1,000.
Yes.
So we can continue negative suction therapy.
Okay. We'll wait for the judges. That is again the right answer. Harita is on a roll tonight. Now moving on to the next session to Dr. Pallavi.
So this is a reasonably more straightforward session. We'll try to run it a little faster in view of time. So please don't take too much time for discussion, and we'll have very small snippets here, not many clinical details. Team 1, 35 years lady with no known comorbidities, recently diagnosed asthma, which she attributed to pollution in her city. She has been suffering from frequent cough. She also gives history of worsening in her shortness of breath despite medications as prescribed by her doctor. On local examination, she had absence of breath sounds in the right clavicular, supraclavicular, axillary and infraaxillary and infrascapular zones, and there is a thoracotomy scar on her right chest. So this is the post-operative X-ray. This is the X-ray which the patient has done. So who's taking the question? Vinay? Vinay, which is the most likely finding for her on her spirometry? There will be a normal vital capacity and DLCO, reduced FEV1, marked bronchodilator reversibility and reduced FEV1 by vital capacity only during exacerbation, or it would be a modest reduction in vital capacity, marked reduction in FEV1, reduced FEV1 vital capacity ratio, normal DLCO and no reversibility on bronchodilators, or it would be a modest reduction in vital capacity, marked reduction in FEV1, reduced FEV1 VC ratio, normal DLCO and marked bronchodilator reversibility, or do you think it would be the fourth choice, which is reduced FEV1 vital capacity as well as DLCO with little bronchodilator reversibility and reduced FEV1 by VC ratio? So what do you think would be her, what do you think is the answer, Vinay?
I think 3, modest reduction in vital capacity, marked reduction in FEV1, reduced FEV upon VC, with normal DLCO and bronchodilator reversibility.
Judges kindly mark. So, so this is a post-pneumonectomy X-ray that we saw. I hope that was clear on the image. And in a post-pneumonectomy space, there is a mediastinal rotation. So there is an upper airway obstruction due to rotation. And then this is what the mediastinal findings are of upper airway obstruction, which is fixed and not dynamic. So then this is the CT of the same patient, wherein you can again see hyperinflation of the left lung and a complete mediastinal rotation with the rotation of the trachea and kinking also, slight kinking of the trachea as well. So Vinay, regarding her further management, which is false. Custom-made 3D carbon fiber printed prosthesis might offer better rigidity and strength to this patient. Tissue expanders would allow gradual rebalancing of the mediastinum and should be advised to this patient. Or would you give her a custom-made 3D carbon fiber prosthesis, and you think it is slightly heavier than a silicone implant? Which is false. You have to tell me which of these options is false. I'll give you a small hint because this is a slightly difficult question. In today's times, custom-made 3D carbon fiber printed prosthesis is available. So which is false in these 4? I mean, that's the standard of care.
Custom-made 3D carbon fiber prosthesis is heavier than silicone implants.
Judges, please. So the answer is that they are slightly heavier, and hence silicone implants are not recommended anymore for post-pneumonectomy spaces. So going on.
So this is the false.
Yes, sir. This is false.
Silicone.
They are lighter. They are lighter, and hence they are preferred over silicone implants. So going on to team 2, the next question is: a 36-year-old lady underwent an uneventful VATS right upper lobectomy for stage 1 NSCLC. She also gives past history of pulmonary tuberculosis, for which she took ATT for 6 months at the age of 14 years. Now she has a persistent air leak at day 10 of surgery. She has been on digital negative suction drainage of pressure 20 until POD 7, and then it was removed despite the persistence of air leak. The apical space remains, so there is a loculated pneumothorax in the upper third of the chest diagram. She has now been referred with ICD in situ for your expert advice and management. So what are the further details that you need to ask in his history from the previous operating surgeon, and why?
Any history of immunocompromisation or
Note all the points that you think are important, and the judges will mark you based on your approach. What are the salient points that you need to know for a further management?
the diagnosis is actually bronchopleural fistula, so it's more than 7 days. I think his history I would ask is any concomitant symptoms like fever, any associated symptoms were there, one that I will ask. And there is obviously tuberculosis that is due to immunocompromisation. So that is might be a cause there. And I will check the air leak if it is on the expiratory or the inspiratory phase. So to check on that, and if it is more than 7 days, I will go for intervention again.
I couldn't understand half the
What
thing.
what did you say?
Really
1,
couldn't
2, 3,
understand.
4. Go.
Yeah, just say it.
There's an echo with the mic, so we can't make out.
This is actually bronchopleural fistula persisting more than 7 days. So the next history I'll ask is if the patient had any fever or acute symptoms in the last 7 days. That history one I'll ask. Next I'll be checking if the patient is having more air leak in the last 7 days, last 3 days within the period. The 14 last is in the inspiratory or the expiratory phase. Like quantifying the air leak. So that I will be checking. If there's obviously this tuberculosis, this immunocompromised state is there. So the patient is on.
No, but she had tuberculosis at the age of 14. Now she's 36.
But the question asked to you was what information from the previous surgeon?
What are the further details? I mean,
What would you like to ask?
What all is important clinically for this patient now?
Any acute infection is there? I do not if acute infection.
More important that any important intraoperative findings which you would like to find out.
The bronchial stem was long or shortened.
Okay, once
the
that.
method of closure.
Yeah, and
things
obviously
like that.
the use of flap closure was used. Was there flap or anything was used during the closure of the stem?
Yes.
Check on that.
And?
And the patient was on steroids or anything?
Okay.
Post-trial. But any activity which actually exertion was there?
I would request the judges to kindly mark based on his 2 attempts of answers. So you need to know the intraoperative findings. You need to ask the previous surgeon whether there was any iatrogenic lung injury. Whether FOB was done before he was referred to you is an important question. The presence of amount of air leak currently in the drain, which you've correctly answered. Presence of pus in the drain, whether it's already infected or not. Preoperative imaging, you need to ask the patient to get all these images because we did not show you any images because the patient did not bring them. You can't decide based on a discharge card. You have asked the patient to get the preoperative imaging and you have to see the histopathology also. We tend to forget when we are seeing air leak that yes, this is a cancer patient. Has anybody checked the pathology and seen whether she needs adjuvant therapy?
And then the other thing is you must also ask intraoperatively whether the surgeon encountered adhesions or not, or what is the degree of adhesion. That's important because that's one of the important causes of persistent air.
Whether the fissure was this thing, you have upper lobectomy, you could have alveolar pleural fistula. How do you know it is deep?
And whether the lung is expanded on table.
Yes.
Fully expanded on table or not.
And is the quantity of air leak decreasing or not? Because actually clinically all you have is a persistent air leak for 7 days, right? But there is only an apical space. There is no fluid collection.
This is a rather subjective question,
Yeah.
but it's okay. Part of the game. Yes, but we can go.
So now which is false? Based on SANG classification of air leak, grade 3 air leak is inspiratory only leak. There is equipoise in literature with regards to the use of negative pressure drainage system in the immediate post-operative period. Fibrin sealants used for persistent air leak are potential growth media for bacteria and can increase post-operative infection rates. And the mechanism of endobronchial valves in the use of persistent air leak is that they prevent air from entering the pulmonary parenchyma distal while allowing air and secretions to travel proximally and thus be drained. So which is false?
Which is false.
So for option 4.
Please speak loudly.
Option 4.
Judges, please answer. Please mark the candidate. So the correct answer is based on SANG classification of air leak. The classification of grade 3 air leak being inspiratory is the Serfolio classification. Kindly go back and read the SANG classification. These are 2 important post-operative air leak classifications which you all must know as part of your curriculum. So question 3 to team 3, a 33 years old young lady has come to you for consultation for thymectomy for thymoma without myasthenia gravis. to follow the ERAS protocol for her surgery, which is true. Pre-operative blood transfusion is superior to intraoperative transfusion if her HB at presentation is less than 10. She should be given anxiolytics on the night prior to surgery. Epidural or paravertebral blocks both can be used with equal results for preemptive analgesia, and desflurane is the preferred inhalational agent in the ERAS protocol. We are strictly talking about the ERAS protocol for thoracic surgery. Please refer to that only.
I would go for option 2. She would be given anxiolytics on the night prior to surgery.
Judges, please mark. Unfortunately, your answer is wrong because based on ERAS protocol, no anxiolytics on the night prior to surgery, no preoperative transfusions, and epidural is to be not given because it does not, it needs postoperative Foley's in certain number of patients. So you should prefer paravertebral blocks for preemptive analgesia. And desflurane is the preferred inhalational agent for as per ERAS protocol. So your second question is intraoperative tenets of ERAS, which is false. I'm asking which is false. Muscle sparing thoracotomy incisions may reduce postoperative pain and preserve muscle function, should be performed where possible. Single drain is preferable to 2 drains for all patients. Intracostal sutures and pericostal sutures for rib approximation have similar outcomes. VATS has not shown to have better long-term pain outcomes when compared to conventional thoracotomy. Surgical tenets of ERAS protocol, which is false.
I would go for option 4. VATS has not been shown to have better long-term pain outcome when compared to conventional thoracotomy.
So judges, please answer. Please mark her.
No, just why do you say that?
Sir, please mark her. We'll show the right answer after that.
No, why does he say that? Yeah. Okay, what is that?
Unfortunately, your answer is wrong. VATS has shown very good pain outcomes in the short-term period. There is no evidence today that says that VATS has shown better long-term pain outcomes. And intracostal sutures and pericostal sutures, initially it was thought that one is better than the other, but as per ERAS protocol, both are same. So that is why we are not drilling holes in our ribs anymore to suture for rib approximation.
So
as far as
false, 4 is false one.
False is 4.
False is true, sir. 4 is true. VATS has not been shown to have better long-term pain outcomes.
No, intraoperative tenets of ERAS, which is false. That means ERAS does not recommend VATS over thoracotomy. It recommends
for long-term pain outcomes.
It has not
this
shown.
is
I don't know.
This is true, you mean? VATS has not shown to have better.
That is true. As a statement, it's true.
That's a
Yes,
statement.
As
That's
a
the correct
standalone
statement.
it's true. But
It's
whether
true.
it relates to the ERAS protocol or not is the
yeah. That statement is true. So the question 4 is a 35-year-old male presented to the OPD with history of long-standing recurrent lower respiratory tract symptoms, including cough and expectoration, which resolved by over-the-counter medications. His symptoms are more severe in the winter months. A CT scan of the chest is done, which is suggestive of cystic bronchiectasis confined to the right lower lobe only and a healthy upper and middle lobes. He undergoes a VATS right lower lobectomy, but inadvertently there is a tear in the right main PA and pneumonectomy is performed. Now, patient has been referred to you for further management.
That's because your profile is
So, patient has undergone a right lower lobectomy. There was inadvertent tear and a pneumonectomy was done for right lower lobe bronchiectasis. So, what are the cardiovascular changes you would expect in the immediate post-operative period for this patient? A decrease in right ventricular ejection fraction and increase in right ventricular end diastolic volume. Post-operative pulmonary arterial pressure falls below 8 mmHg but recovers over the course of 3 to 6 months. Decrease in right ventricular ejection fraction and right ventricular end diastolic volume both. No change in cardiovascular parameters as the patient was healthy and fit preoperatively.
So you want to ask what is true?
Yes.
Only one is true.
I think
After a pneumonectomy.
it's 3, decrease in right ventricular ejection fraction and diastolic volume.
Judge panel, please mark the candidate. So unfortunately the correct answer is there will be a decrease in right ventricular ejection fraction and increase in right ventricular end diastolic volume. So the intercostal drain of the patient was removed on the 3rd post-operative day, and on 8th post-operative day patient expectorates a large amount of blood-tinged fluid in sputum. There is a drop in the fluid level on chest x-ray and you suspect a bronchopleural fistula. What would be your next course of management? Immediately take the patient for a redo surgery in the emergency OR and perform a right thoracotomy and repair of the fistula. Perform an urgent bronchoscopy and close the fistula using glue. Take the patient for surgery in the next available OT slot and perform a Clagets procedure. Insert an ICD followed by a bronchoscopy.
Fourth. Insert
Judges?
ICD followed by
Yes, your answer is correct. Why we are saying that is that immediately you cannot take the patient for a redo surgery. So coming on to chest infections outside lung, we are going to go a little fast on this section. You have to answer sooner and we are not going to give much time on this. So now that all of you are used to it, quickly choose who's answering and we'll finish this within 15 minutes.
15 minutes?
Yeah.
Now finish within 15 minutes and that's it.
Yes, sir.
Yeah,
No, sir. This section, so we have
So
more.
we have another section?
Yes, sir. All of them have to answer once
You
more.
mean to say all of them have to
Yes.
do that? That means 9.
No, so this is the 4th section, right?
6 sections, madam.
6, okay.
So can we stop at 5 or something? Everybody gets that?
Continue.
Okay,
People are all very lazy.
A 20 years young gentleman residing in slums developed right-sided chest pain 3 months back. A month after his friend developed cough with yellowish sputum. He ignored the pain and subsequently he lost his appetite and started developing fever every evening. A month later he became very weak and was bedridden. One night, due to significant shortness of breath, he presented to a local government hospital. In view of his acute shortness of breath and reduced air entry on the right side, an emergency thoracostomy was done without a skyogram. On needle aspiration, there was purulent blood-tinged output. Please see every point of the question very carefully. On ICD insertion, there was frank pus discharge, which was slightly blood-tinged with massive air leak. Post ICD insertion in the skyogram, this was the picture. So there's an ICD in situ, the lung has not completely expanded, there's an air fluid level. So all of the following should be done next, except.
Next question.
Can I tell the reason?
No, you got the answer already.
Yeah, so we'll just go to the next question and we'll give marks on that. I think you can skip this. Because the answer is already seen.
We'll give 10 marks for the second part of this question.
Yes, right.
Does that work? So the answer is why we are saying we have to do a repeat thoracocentesis, because the fluid came out to be blood tinged, and in a blood tinged fluid both sensitivity of CB0, LPA goes down. So you're supposed to do a repeat thoracocentesis. Yes, sir. So the patient had a significant relief in his shortness of breath. His weight was 30 kg and his MGIT smear revealed MTB detected and culture reports and DST are awaited. He was given anti-tubercular treatment and continued on intercostal drain for 4 weeks. There was no resistance detected in his MGIT till date, but the final report at 42 days was awaited. His GC improved slightly and his ECOG status improved from 4 to 3. And he gained 3 kgs of weight. However, the air leak in his drain remained the same and there was no significant change in his skyogram. There was no mediastinal shift noted when the patient was placed on an open drain. CECT's chest is suggestive of this. You can see there is a bronchiectatic right lung with an air fluid level and a space. So all of the following are reasonable further steps except. So in this question gets marked out of 10, so please answer carefully. All of the following are reasonable further steps except VATS decortication and on-table decision based on intraoperative findings. Continue intercostal drain in view of low weight 33 kgs and bilateral parenchymal disease. Plurocutaneous window thoracostoma in view of low weight and bilateral parenchymal lung disease. All of the above are reasonable options.
I think option 2, ma'am. They have not mentioned the time limit to continue the ICD, and VATS decortication and plurocutaneous window both seem reasonable.
Judges, please.
Except is 2.
Yeah. Except 2. Judges, please mark. We'll try
you're
to.
saying
So you multiplied this into 2.
No, no,
Yes,
what,
sir.
what was the answer?
She has said 2. She has picked 2.
All the following are reasonable.
But if 2 is correct, then 4 cannot be correct at the same time.
Sir, we'll just talk about the options. Please mark the candidate on based on their approach, and then we'll find the right answer. All of us. All of the above are not reasonable options, and 2 is the answer based on even the article by Elossier, wherein persistence of an intercostal drain over a long period not just worsens the course of the patient and causes him pain, but also puts him at a risk of repeated infections, and hence it should not be recommended.
So because number 2 is not a reasonable option, so all the above are reasonable options is also wrong. That's what I'm saying. Strictly speaking.
Yes,
agree.
English, that's English. The professor and English speaking.
Question
So-
framing the question also is correct.
That's what I'm saying.
So there are 6 rounds and so many questions. I think we have to give the prize money to Pallavi and finish the quiz.
So 10% of the prize money. Okay.
Yes.
So a 34-year-old lady with past medical history of hypertension, unvaccinated for COVID-19, presented to the emergency with worsening chest pain, dry cough for 3 days. Chest pain was located on right side, sharp in nature, aggravated by cough and touch, no relieving factors. There was no fever or shortness of breath. At presentation, her vitals were stable, saturation 98%, review of systems unremarkable. This is the chest X-ray. So I hope you can see the pathology on this chest X-ray. 3 days later, this is the patient developed septicemia, TLC 31,000, creatinine 4, sugar 400, severe metabolic acidosis. And this is the repeat chest X-ray. So just to show you again, COVID-19, initial X-ray, 3 days later, this is the X-ray. So the part 1 is which is true. She has developed COVID pneumonia followed by COVID empyema. She has developed community-acquired pneumonia with secondary pleural effusion. She has developed COVID with secondary mucormycosis. She has developed PTB with empyema. This is the first X-ray, this is the second. Your marks are based on your approach. You don't need to necessarily give me the right answer.
Can you please show the options here?
Option 2. 2.
Judges, please mark. So the correct answer that was in this patient was that she developed secondary mucormycosis. Patient had bad sugars. Patient went into septicemia, and the X-ray picture completely changed within 72 hours. So that is classical of how a mucormycosis presents, and a community-acquired pneumonia does not worsen this bad so fast in a known diabetic patient with COVID. So on day 4, she developed this on her right chest wall. So all are reasonable next steps except you would give liposomal amphotericin B, intercostal drainage and debridement of the chest wound, amphotericin B and urgent thoracotomy with drainage or decortication, liposomal amphotericin, thoracotomy with drainage and debridement of the chest wound, no surgical intervention in view of the poor prognosis disease and poor general condition of the patient. I am saying all are reasonable except which of the one is not to be done at all is the question. Which is it that you will not do at all? When you are explaining the options to your patient, which is the one option you will never give?
Option 4. No surgical intervention. Because we
Judges,
anyway
please
we have
mark.
to give lap foot.
Actually, I think we might have a discrepancy here as well. We found this to be the answer. Why? Because in a creat of 4, you cannot give amphotericin B. You have to give a. Let me complete, please. Then judges also disagree with me, I'm sure. And so, yes, liposomal amphotericin B followed by thoracotomy, drainage, debridement is what should be done. And in a patient who has already developed a lesion on the skin, then it is a very highly disseminated disease, and patient has to be told that yes, this is an option of no surgical intervention in view of poor prognosis disease and poor general condition of the patient. If the patient is in full-blown sepsis, this is one of the options that has to be explained well to the patient. But yes, amphotericin B as a clinician we cannot give in a creatinine which is 4. But I'll I see that the judges have marked you based on the... So coming on to the next question, a 59-year-old gentleman presented to the emergency department following a collapse, gave a prior history of toothache for 1 week, for which he had sought treatment and was prescribed short course of oral augmentin. On examination, the patient is in acute septic shock. There is complete trismus coupled with large tense erythematous bilateral submandibular submental swellings, tenderness to palpation extending past the clavicles. Patient's speech is dysarthric. Patient's respiratory efforts are increased. There is reduced chest expansion on the left side, and you are called by the medicine team for advice. So which of the following advice would you give to this patient? One is call an ENT surgeon, urgent chest X-ray thoracocentesis, higher antibiotics and ICU management. Reassess after CCT thorax, involve a head and neck specialist and appropriate ICU management. Shift the patient to emergency OT in view of septicemia and collapse with respiratory distress. Insert chest drain and appropriate ICU management. The respiratory efforts are increased. There is reduced chest expansion noted on the left side. Patient is slightly tachypneic, but on room air, he is having reduced chest expansion.
Read the second last point. That's important.
So these are your options. Call an ENT surgeon, urgent chest X-ray thoracocentesis, higher antibiotics, ICU management. Reassess after CCT thorax, involve head and neck specialist, appropriate ICU management. Shift the patient to emergency OT in view of septicemia and collapse with respiratory distress, or insert chest drain and appropriate ICU management.
Option 1, call an ENT surgeon, urgent chest X-ray thoracocentesis with higher antibiotics, ICU management.
Judges, please mark. So we found the answer to be correct, to do a CCT thorax in addition to involving a head and neck specialist and appropriate ICU management. Why? Because the patient was slightly tachypneic but not in respiratory distress right now, and he had a bigger trismus and other problems, so you have to suspect a descending mediastinitis in this patient. So this was the CCT of the chest and the neck, where you can see the infection which is tracking posteriorly. So all of the following must be done except you have to do a surgical tracheostomy, release the copious volume of foul-smelling purulence from the pretracheal space, debridement of the necrotic tissue from the neck, extensive lavage with warm normal saline and chest drains, sternotomy and complete drainage with mediastinal and chest drains, broad spectrum antibiotics until we get the culture sensitivity reports. All of the following would be part of your procedure except.
Sternotomy and complete drainage with mediastinal and chest drain, that is not something I would do.
Judges, please mark. So the answer was sternotomy, because as we saw, the collection was mostly posterior. It was not retrosternal at all. So yes, you would not offer a sternotomy. Instead, you will try to drain it from the neck. So the next question for team 4, a 35-year-old male chronic alcoholic presented to the OPD with fever, nausea, vomiting for 2 days. On examination, he was found to be restless, tachycardic, tachypneic, along with right upper abdominal tenderness and reduced breath sounds in the right lower zone of the chest. Performance status is ECOG 3. Chest X-ray and ultrasound abdomen reveal a ruptured liver abscess through the diaphragm. So this is the initial X-ray of the patient as we saw her. What would be your next step in management? Therapeutic pleural tapping and IV metronidazole therapy. Intercostal drain in the right chest, IV metronidazole, pigtail drainage of the liver abscess followed by reassessment. Intercostal drainage of the right chest and IV metronidazole followed by reassessment. All of the above are acceptable next steps.
Intercostal drainage of right chest and IV metronidazole, pigtail drainage of the liver abscess followed by reassessment.
So answer 2. Judges, please mark. Your answer is absolutely correct. So this is exactly what was done. A right intercostal drain was inserted and 2-liter anchovy sauce fluid was drained. Patient immediately feels better. The next day you notice an air leak in the drainage bag on coughing. So what would be your next step? Continue intercostal drainage, assess after completion of metronidazole therapy, or to consider pleurocutaneous window in view of air leak and poor GC. consider a low thoracotomy with decortication debridement with liver cavity debridement and diaphragmatic repair, or a right thoracotomy with decortication and later refer the patient to a gastroenterologist for further management.
Continue intercostal drainage and assess after completion of metronidazole therapy.
Judges, please mark.
What is the answer? You said?
First one.
Continue the intercostal drainage and assess the patient after completion of medical management.
So the correct answer is to offer surgery. In tubercular abscesses, when there's an air leak, you are supposed to wait. But when it is an amoebic liver abscess or a pyogenic abscess, you need to go in early. And since we are doing a surgical intervention, it is wise to do the liver plus the chest together.
Can I ask the question?
Yeah.
Because it is acute state and the abscess is ruptured right now and we placed an ICD and drain. So diaphragm may not hold the sutures if we take the sutures also. So what I generally asking for it, continue medical management. There are already 2 drains are in situ and the patient will improve and he will nutritionally we can build up the patient.
See, we accept your approach and that is why the judges have given you marks.
That is why we give you different marks. Yeah.
Based on the answers.
Your approach is okay, but what happens is that increases the chance of lung getting trapped. While in such situations, or acute pyogenic situation, if you intervene early, there is better chance of lung expansion being achieved. So it's a subjective thing, and every approach.
Everybody agrees with your. I mean, everybody has given you marks for your approach.
So coming on to the last but one session, the airway session.
It has to be the last, or is over.
Yeah. Or you're not getting any dinner.
There are 2 more, sir. 33 years, gentleman, non-smoker, no known.
We have to enjoy the dinner.
We appreciate your effort, but I think it's.
So, but if we had stopped at the last session, it would have been a equitable distribution. Now that we've started, we need to run through.
Then we can do one more.
We have to do just.
How many questions?
How many questions? No, not questions. How many sessions we have done?
We have done nearly 4.
We have done 4 questions.
4, which is okay.
We've already done 4, sir.
हाँ तो इसमें हम घूम के तो आ गए ना ये लास्ट है ना.
घूम के नहीं है सर 12 स्टूडेंट्स में से कुछ ने ज़्यादा क्वेश्चंस अटेम्प्ट कर लिए कुछ ने कम.
So then eliminate the last one.
So that is why I asked in the middle. If we want to stop, we can.
So they are 12 and they have to answer 24.
Yeah.
That's why you need 6 sessions.
So that is why 12 may we have.
You've done 3, no?
No, we have done 4 now, sir.
No, we have done 3. So all of them have answered, and then the 4th one is extra. So
के basis पे.
So you assess them under 3 things.
Assess them on 3. You see, it is important for the team to enjoy the dinner also.
They have done a great job. They also need the butter paneer, butter chicken.
I mean, otherwise it will go on till 8, 9.
Thanks a lot for the effort. Not the effort of Pallavi.
Pallavi, all the judges are very, very happy they are not at the other end.
Yes.
Second point.
Send the judges all these questions. If judges don't pass, their degrees will be taken.
Exactly.
I don't want to.
Judges will not pass. Let me tell you.
Yeah.
Judges will not pass.
Yeah. I have serious doubts about my passing.
Yeah, we'll take a photograph. Yeah.
It's a very well done job. What do you say? And if you are not able to share the money correctly, then be generous with each other.
Have a private party, don't call us and enjoy. All of you.
Because your hair lands a distinguished hair.
No, we are not. We don't need to.
All the students, please.